This week, we're going to be dealing with the problem of anemia found in Chapter 9 in your textbook. Among hematological defects, anemia is possibly the most common disorder in medical practice. Anemias can be classified as either nutritional or non-nutritional, but in general they refer to a defective hemoglobin formation. Now, when we talk about non-nutritional anemias, we really refer to things like thalassemia, sideroblastic anemia, and also anemia of chronic disease. Now, anemias can also be classified according to their color and their size. For instance, anemia could be hypochromic, microcytic. This means hypochromic is low in color and microcytic is small in size. So anemias that are hypochromic signify a problem in hemoglobin synthesis. And so it shouldn't be so much of a surprise that the association between hypochromia and microcytic iron deficiency anemia is very strong. It turns out that 90% of the people diagnosed with hypochromia tend to also be iron deficient. Now, normocytic, normochromic anemia is basically an anemia of normal coloration and normal red blood cell size, and this tends to be associated with the anemia of chronic disease, and we'll get into more detail about this particular anemia. Normocytic macrocytic anemia is an anemia of normal coloration, but of large red blood cell format, thus macrocytic. And this tends to be associated with megaloblastic anemias and are diagnosed with a large MCV, mean corpuscular volume. Anemia of chronic disease is important because it shows up in a lot of hospitalized patients. There's a four-model system of assessment consisting of serum ferritin, transferrin saturation or transferrin, erythrocyte protoporphyrin, and mean corpuscular volume, MCV. These four markers are useful in helping to discern if there's iron deficiency anemia taking place or not. On a worldwide basis, anemia of chronic disease is the second most common anemia, and specifically within hospitals, medical, and surgical settings, this form of anemia is certainly the most common. I encourage students to take the time to read the section 9.3.3 on anemia of chronic disease in the textbook. It goes through a thorough description of the different etiologies and causations that are tied to this particular condition. So while there is a multifactorial approach here, let me focus on a couple of points that I think are quite significant in anemia of chronic disease. There is in particular a macrophage iron withholding, in other words, a difficulty for the body in releasing iron into the system. There's also a shortened red blood cell lifespan, a decline in iron absorption from the duodenum, and a small increase in blood volume. Now, the anemia in this setting acts really as a compensatory mechanism to the trauma and the infection by increasing the fluidity of the blood. So this sequestration of the iron by the reticuloendothelial system, also referred to as the macrophage iron withholding, may actually be beneficial to the body as it keeps the iron from the microorganisms, thus preventing the growth of pathogens. So it's actually a security mechanism to preserve the body. Now, there are consequently symptoms, hematological manifestations from this condition that resemble that of iron deficiency, but it's not a perfect match. So I'm going to draw up here a comparison between anemia of chronic disease on the left-hand column and iron deficiency anemia on the right-hand column, and look at the different blood markers and how they are similar and how they are dissimilar from each other. So I've highlighted in yellow those markers that are quite similar. We can see in iron deficiency anemia that the hematocrit, which is the number of red blood cells relative to the volume in the plasma, tends to go down in iron deficiency anemia, but it also goes down in anemia of chronic disease. We can see also that the erythrocyte protoporphyrin, which is the protein that requires iron to combine with it to become hemoglobin. So in iron deficiency anemia, because of the absence or the deficiency in iron, there's not enough iron to combine with the EP. So therefore, there is less production of hemoglobin, and there is a rise in the protein erythrocyte protoporphyrin. So we tend to see the EP go up because there's actually not enough iron. We see the same thing occurring in iron deficient in anemia of chronic disease, because not because so much there's an absence of iron reserve, but because there's an iron withholding. So even though it's a different cause, the endpoint is still the same. There's still not enough iron to combine with the erythrocyte protoporphyrin. So much like iron deficiency anemia, we see the EP actually increasing in concentration. Now we see hemoglobin going down in iron deficiency anemia, and that's because there's insufficient iron reserve that takes place. But in anemia of chronic disease, it's not so much the iron reserve that goes down, but we see that there is a decline in iron absorption from the duodenum. There's a shortened red blood cell life as well. And we can see that there's a small increase in plasma volume, thereby diluting the hemoglobin somewhat and causing the concentration to go down due to a dilutional effect, if you will. So we see erythrocyte protoporphyrin declining, hemoglobin declining, and hematocrit declining. And so it's very difficult from the outset to distinguish if the cause is due to iron deficiency anemia or if the cause is due to anemia of chronic disease, because they have both the same manifestations. So what is different between them is the fact that the mean corpuscular volume, the MCV, tends to be low in anemia or in iron deficiency anemia. And this is a reflection of the size of the red blood cell. We know iron deficiency anemia tends to be, of course, microcytic, so low in size, right, a smaller size of the red blood cell. And we know that the iron reserves reflected by serum ferritin tends to also be low, and it tends to occur earlier in the depletion phase. So that tends to be low. And whereas in anemia of chronic disease, we see the MCV to be normal initially, and we find also the ferritin levels to be normal. So these are the two markers that are most reliable in helping the physician determine if the low hemoglobin and low hematocrit that they see in the blood smear is due to one or the other of the types of anemia. So if hematocrit is low, hemoglobin is low, but the MCV is low, and the ferritin is low, then the physician can conclude it's iron deficiency anemia. But if the hematocrit is low and the hemoglobin is low, and in addition, of course, the erythrocyte protoporphyrin is high, but that the MCV is normal and the ferritin is normal, then it can't be iron deficiency anemia, because these tend to be actually on the decline. So the physician then can more accurately conclude that what they're looking at is an anemia of chronic disease. Now, next I want to look at the TIBC, which is the total iron binding capacity. And in iron deficiency anemia, that tends to be elevated. The TIBC tends to reflect the number of free iron binding sites that are located on the transferrin protein. Well, what does that mean? Well, basically in iron deficiency anemia, the binding sites for iron on the transferrin protein tend to go up, because it's a compensatory mechanism. If the body is deficient in iron, then the transferrin increases its number of binding sites so it can saturate it as much as it can and actually allow then a replenishment of the iron reserves. So it's a compensatory mechanism. So we tend to see, of course, this TIBC go up. Now, transferrin also, likewise, tends to go up as well, because the number of proteins tend to increase in order to compensate for the lack of iron. So the idea is also this is a compensatory mechanism to capture as many iron atoms as it possibly can. So we see transferrin going up in iron deficiency anemia. And then we see the transferrin saturation, the degree to which these binding sites are saturated. Well, that actually goes down in iron deficiency anemia. And if you can follow the logic being that even though there's an increase in sites, TIBC, the degree to which those sites are saturated will go down in iron deficiency anemia simply because there is a lack of iron atoms. Now, what becomes confusing in all of this is that the TIBC will tend to go down and to be low in malnutrition. The transferrin saturation will also tend to be low, and transferrin levels will tend to be low in malnutrition. So relying strictly on TIBC, transferrin, and transferrin saturation to determine if it's iron deficiency anemia or anemia of chronic disease can be very misleading. This is why the model relies strictly on using the MCV and the ferritin and to see how those react in order to distinguish between the two types of anemia. So this means in anemia of chronic disease, this is the profile that we would normally see. An MCV that is normal and maybe slightly elevated, a serum ferritin that is high or maybe normal, plasma iron, which is totally unreliable either for iron deficiency anemia or for anemia of chronic disease, simply because plasma iron tends to have diurnal variations, and so the concentrations will be up and down depending on the time of the day. So hematologists give very little value to plasma iron. Transferrin itself will look normal or a little low. The TIBC will be low, and the erythrocyte protoporphyrin will tend to be high. So again, the 4-variable model will allow the physician to be able to determine whether or not this is one type of anemia or the other. So in other words, what I'm encouraging students to rely on here to be able to have a more profound understanding is they must look at the serum ferritin and they must look at the MCV specifically. So if the transferrin saturation is declining, and if the erythrocyte protoporphyrin is increasing, both characteristics seen in both types of anemia, but if the serum ferritin is normal and the MCV is normal, then the hematologist or the physician can conclude that it's not iron deficiency anemia, but rather that it is anemia of chronic disease. But if the transferrin saturation is low and the erythrocyte protoporphyrin is high, and then the serum ferritin is low and the MCV is low, then the hematologist or physician can conclude that this actually is an iron deficiency anemia. It's very important that students acquire a very good understanding of this basic concept in order to allow them to more accurately and correctly, of course, ascertain whether or not a patient is suffering from chronic anemia of chronic disease or iron deficiency anemia. And there will be questions later on that will help you sort of wrap your mind around it. But it's good that you memorize this system so that you have it really fully integrated and that you are able to say that you know it cold. So now let's do a little example. For instance, you're looking at blood values and you see that the serum ferritin is low, and you see that the MCV is low. The conclusion then is that this person is suffering from iron deficiency anemia. The MCV indicating a mean corpuscular volume that is low, indicating a microcytic anemia, and the serum ferritin indicating that the iron reserves are low, and consequently an indicator of early iron depletion. Here's another example. Let's say you look at serum ferritin and it's normal, let's say you look at erythrocyte protoporphyrin and it's high. A high level of erythrocyte protoporphyrin normally suggests iron deficiency anemia, but you know that EP also goes up in anemia of chronic disease. Let's look at the MCV. It too is normal. Well, this can't be an iron deficiency anemia. The conclusion here is that it's an anemia of chronic disease. Now I want to take a look at nutritional anemias. Now there are two broad categories that we can discuss. First is iron deficiency anemia, which we've already seen a little bit of. And then the next one is a macrocytic anemia, and a macrocytic anemia that is based on vitamin B12 and or folate deficiency. This is called megaloblastic anemia. In looking at iron deficiency anemia, the first thing that's important to do is understand how the different blood markers react in the different phases of iron deficiency anemia. You can see that the first stage of iron deficiency anemia, or leading towards full outright iron deficiency anemia, is depletion, or in other words, iron depletion. Then there's the second stage of depletion, and then there is the third stage of depletion, which tends to be outright iron deficiency anemia. So let's see what takes place. First, the serum iron tends to go down pretty quickly, but again, as mentioned earlier, the hematologists tend to give very little value to serum iron alone, because serum iron will tend to change, will go up and down depending on the time of the day. Now, the second is serum ferritin. Serum ferritin is a reflection of iron storage, and it will respond very quickly, in fact, in the first stage of depletion, indicating that the reserves are on the decline. Oftentimes, serum ferritin is used as a way of screening for the potential danger of outright iron deficiency anemia occurring eventually. So it's a good way to stop it in its tracks and to start a therapeutic diet, for example, to help the person recover their iron reserves. The other one is transferrin saturation. You can see that the saturation levels start to decline near the end of the second stage, and they tend to be at their lowest in the third stage of depletion, which tends to coincide with the outright iron deficient state. You can see also that erythrocyte protoporphyrin tends to be at its highest in the third stage, or in the stage of iron deficiency anemia, and hemoglobin also tends to be at its lowest in the third stage as well. Hematocrit, much like hemoglobin, will also tend to be at its lowest during the third stage. Now, I want you to take note also that hemoglobin and hematocrit don't change at all during the first and second stages. So these proteins are not really used at all, nor is erythrocyte protoporphyrin or transferrin saturation used in order to detect early changes in iron status, right? When they are actually abnormal is really primarily in the third stage, when outright iron deficiency anemia actually occurs. Now, there is a danger of misdiagnosing iron deficiency anemia, because indeed similar blood value profiles can occur with genetic abnormalities such as thalassemia or sideroblastic anemia. We also know that anemia of chronic disease can also lead to a misdiagnosis. We also know that copper deficiency can lead to a misdiagnosis, because a lack of copper, if you remember, leads to decreased ceruloplasmin, which is a transport protein, which makes iron unavailable to the body. We know that blood loss will also cause reticulocytosis, which really means an abundance of reticulocytes, which are red young blood cells, which tend to create a higher MCV, or normal, slightly higher to normal MCV value. And we know that there is in blood loss a polychromatic red blood cell. That means a variance in blood color, right, in the color of the red blood cells. So it's pale in some cases and a little higher in other cases. So it's called polychromatic. And in addition, there is hemolysis that will cause a misdiagnosis. Hemolysis is really the rupturing and death of the red blood cell. So as part of the nutritional anemias, we have megaloblastic anemia, which is a macrocytic anemia, a large red blood cell anemia, as opposed to a microcytic anemia, which we saw in anemia of chronic disease, as well as we saw in iron deficiency anemia. But now we're looking at a large red blood cell, and there are many reasons why we can have a large red blood cell anemia. And we won't go into the details. It takes a real true course in hematology to get into that. But suffice to know that among the causes of macrocytosis or macrocytic anemia, there is the cause of vitamin B12 and or folate deficiency. And when that occurs, we say that the macrocytic anemia is really a megaloblastic anemia. Well, it's very important to look at the biochemical origins of megaloblastic anemia. This slide depicts specifically folate metabolism. I want to start the discussion by focusing on dietary folate, which really provides the body with methyl tetrahydrofolate, which is the inactive form found in fruits and vegetables. This methyl tetrahydrofolate needs methylcobalamin, otherwise known as B12, in order to become an active form of folate, which is tetrahydrofolate. This tetrahydrofolate then is biologically active and capable of being used then in DNA synthesis. It is also worth noting that methyl tetrahydrofolate plus homocysteine is necessary for methionine synthase to synthesize the amino acid methionine. Consequently, when dietary folate is deficient, then the reaction of methyl tetrahydrofolate with homocysteine can't proceed towards the synthesis of methionine. Consequently, we see homocysteine levels in the blood increase. So in other words, if blood or serum homocysteine levels are elevated in the blood, that can tend to signify that there is a folate deficiency. However, the possibility of a folate deficiency only is difficult to come by, especially if we consider the role of methylcobalamin in this biochemical pathway. Indeed, the mechanism works like this. The methyl of the methyl tetrahydrofolate gets transferred to methionine synthase. Methionine synthase then transfers the methyl over to cobalamin, creating methylcobalamin. However, in the absence of cobalamin, this transfer does not take place, therefore leading also to a slight increase in homocysteine as well. Now, the second pathway I want to examine involves vitamin B12 metabolism. This particular pathway, called the methylmalonic acid pathway, strictly is limited to the involvement of B12. And we can see how methylmalonic acid, through the enzyme hydrolase, becomes methylmalonic acid. And we see how methylmalonic acid, through the involvement of mutase and also of cobalamin, becomes succinyl-CoA. In the absence of B12, what we see then is an accumulation of methylmalonic acid, no longer able then to proceed in the reaction towards the formation of the product succinyl-CoA. So in the absence of cobalamin, CBL, we see a buildup of methylmalonic acid. So therefore, in the blood analysis, whenever methylmalonic acid increases, we are assured that what we're talking about here is exclusively a B12 deficiency. We do not see any involvement of folate in this particular pathway. So now let's step back and take a broader view of the problem, and let's look at the diagnostic approaches to both folate and B12 deficiencies. Well, let's begin with serum folate. Serum folate levels tend to be low when dietary folate intakes are low as well. So it's a reflection of the recency of the folate intake. Now, let's add a little complexity. Serum folate can also increase in instances of B12 deficiency. And why is that? Well, in B12 deficiency, what happens is the tetrahydrofolate in the blood will tend to increase because it doesn't get demethylated. And so when we measure serum folate, we're actually measuring serum methyl tetrahydrofolate. So in the absence of B12, we'll tend to see a rise in the folate levels, serum folate specifically. The red cell indices is referring to the MCV, the mean corpuscular volume, and in both folate and B12 deficiency, the MCV tends to increase. Now, serum methylmalonic acid, when it rises, exclusively means that there is a B12 deficiency. There's no evidence of any involvement of folic acid in this particular pathway. Whereas serum homocysteine typically will be elevated in a folate deficiency, but we also saw biochemically that it can also be high in a B12 deficiency. Now, as a diagnostic strategy, it's also possible to use serum methylmalonic acid, serum homocysteine, and serum folate to come to some kind of accurate resolution as well. So, for instance, if serum folate happens to be normal, if serum homocysteine is high, and if methylmalonic acid is high, then there's a good chance that you could probably conclude in a B12 deficiency. However, in another example, if the serum methylmalonic acid is elevated, but the serum homocysteine is on the lower side, not abnormally high, but probably just a little highish, but the serum folate is quite normal, it's a very much higher likelihood that what we're looking at is a B12 deficiency because the MMA is elevated. In another example, if the serum folate level is not below the critical cutoff of 3 micrograms per liter, and if the homocysteine is elevated and serum methylmalonic acid is elevated, then we can conclude as well that there is a B12 deficiency. Now, however, to make things a little complicated here, we do know that serum folate levels can also rise in a B12 deficiency. So they don't always rise, but they can be normal to elevated. And if the serum folate levels are elevated, if the serum methylmalonic acid is elevated, and if the serum homocysteine level is elevated, then we can also, in this case, conclude in a B12 deficiency. So on the other hand, if serum folate levels are below the critical cutoff of 3 micrograms per liter, and if serum homocysteine is elevated, and serum methylmalonic acid is normal, then we're looking more than likely at a folate deficiency. If, on the other hand, the serum methylmalonic acid, the serum homocysteine are elevated, and the serum folate is below that critical cutoff, we might be looking at both B12 and folate deficiency. So if you have in the blood values that we just looked at a confirmation of B12 deficiency, but you're wondering what is the cause of the B12 deficiency, then you need to use the Schilling's test or the modified Schilling's test to confirm why the B12 deficiency is taking place. Okay, so there are two stages in the Schilling's test. The first consists of administering an oral dose of crystalline cobalamin containing a radioactive cobalt, and then measuring the amount of radio-labeled cobalamin in a 24-hour urine collection. Patients that have a B12 deficiency, or in other words, a pernicious anemia, will excrete less than 3% of the dose of radio-labeled cobalamin that was administered, whereas non-deficient patients will have a much greater amount, more than 8% of the administered dose. So what's the reasoning behind this kind of test? Well, in a state of deficiency, in other words, of B12 deficiency, more of the radio-labeled B12 will be absorbed because the body needs it. In a state where the body doesn't require B12, then not as much will actually be absorbed. So then, if the amount excreted is abnormally low, then the second stage will be implemented. In this second step, an oral administration of a labeled cobalamin and an intrinsic factor is given 3 to 7 days later. If the urine value subsequently collected is normal, then it infers that the intrinsic factor was truly missing and consequently necessary for proper absorption. So in that sense, the Schilling's test is really confirming that the reason for the low B12 is because of poor absorption, and the reason for the poor absorption is that the body is lacking the intrinsic factor which is necessary for the absorption of B12 in the ileum. So now, what is the modified Schilling's test? Well, rather than using crystalline cobalamin, radioactive B12 is incorporated into food products like chicken and eggs, a protein food of sorts. This method can correctly diagnose poor absorption of protein bound cobalamin and would be relevantly applied to elderly with low gastric acidity. What's taking place then in this case is that there's not enough acidity to break down the protein that contains the B12 and thereby making less B12 available. So this in a sense would confirm achlorhydria found mostly in patients over the age of 50. Due to the fact that the parietal cells are not secreting enough hydrochloric acid, again, to break down the protein. What's important to understand here is that the Schilling's test is not used to confirm a B12 deficiency. I hope students really grasp this subtlety. The Schilling's test is really used once B12 is confirmed, and what it does is it basically is able to confirm the reason for the B12 deficiency. And in the pure Schilling's tests, they're looking here at the intrinsic factor. And with the modified Schilling's tests, they're actually showing that they're able to confirm that it's due to the fact that there's a lack of hydrochloric acid. So now let's take a look at a few case studies in anemia. These case studies are found in the textbook in greater detail. In this lecture presentation, I'm going to go over the highlights. So in this first problem set, we have a serum iron of 0.62 milligrams per liter. The normal is 0.8 to 1.5. So clearly there's a deficient iron. But again, remember, iron is not a really reliable indicator. Let's look at the total iron binding capacity. It's 4.42, so it is within the normal range. The erythrocyte protoporphyrin is 1.1 milligram per liter. The normal is 0.4 to 0.7, so the EP is slightly elevated. This is a young 20-year-old woman who presents with tiredness and facial pallor. You could read more about the case in the textbook. We can conclude from this particular case that possibly we have iron deficiency anemia because of the elevated EP and because of the tiredness and the facial pallor. Now, if you take the serum iron and you divide it by the TIBC, you get 14%, and this is the transferrin saturation, serum iron divided by TIBC. A normal serum transferrin saturation is 20 to 50. So at 14%, that also is a confirmation of an iron deficiency. However, we would want to do a serum ferritin and an MCV to confirm it and to rule out anemia of chronic disease. In the second problem set, we have a normal plasma iron. We have a transferrin, which is at 1.24, and the normal being a little over 2, so it definitely is under. Plasma ferritin at 12 is definitely under the norm, and the transferrin saturation appears to be normal. This is a 55-year-old who complains of general weakness, tiredness, and abdominal pain. The overall presentation then suggests that the low levels of serum transferrin indicates early depletion, but the transferrin saturation being normal suggests that that it has not reached a third stage anemia. So what we're looking at is the likelihood of a first stage of iron depletion. We can rule out possibly anemia of chronic disease because the serum ferritin is actually low, and in the anemia of chronic disease, serum ferritin tends to be normal or slightly elevated. Next, we have a case of a young lady, 18 years old, emaciated, university female freshman, complains of low energy, overly tired for 6 months, and with abdominal pain in the lower left quadrant. She's lost 5 pounds in the last 6 to 8 months. The general symptoms are poor appetite, facial pallor, pale conjunctiva, thinning hair. Her blood chemistry indicates low hemoglobin, low hematocrit, low MCV, and low MCH. Her red blood cell count is low, and her transferrin is mildly low. Additionally, the interpretation of the biochemistry. So the retinol binding protein, the RBP, the hematocrit, and the hemoglobin indicate a possible iron deficiency anemia and a protein malnutrition. Indeed, a low retinol binding protein in the absence of a retinol or vitamin A deficiency is really symbolic of a protein deficiency. Additionally, the low hematocrit and hemoglobin actually indicate an iron deficiency anemia. Hepatic and pancreatic functions appear to be normal. The amylase is normal. The GGT and the ASAT are also normal. Amylase will tend to be elevated in pancreatitis, so in this case we can rule out pancreatitis. The GGT and ASAT are indicative of, in this case, normal liver function. So what can we come up with as a likely diagnosis? Well, because the MCH is low, that is indicative of hypochromic, and because the MCV is low, that's microcytic anemia. Furthermore, we have the hemoglobin and the hematocrit, which are low. So that's indicative also of basically iron deficiency anemia. The only unusual component is the transferrin, because in iron deficiency anemia, the transferrin should be low, but it should be high rather. But what we see is that it's low. And what we understand that's taking place here, because of the RBP, the retinol binding protein, this suggests that there's protein deficiency, certainly in the absence of vitamin A deficiency. Now, we haven't been able to confirm vitamin A deficiency, so we can stay with the supposition that we've got protein deficiency. So consequently, because transferrin protein is also sensitive to protein deficiency in that it has a tendency to decline or to decrease in protein deficiency, we see it going the other way rather than increase because of the iron deficiency. We see it kind of low because of the protein deficiency. Now, the abdominal pain, because it's located in the left lower quadrant, suggests that it's constipation, and that will have to be confirmed by X-ray. So what else can we do to complete her story? Well, I think you're quite correct. Let's do the BMI. And if we do the BMI, we see that her BMI is 18.7, which is rather low, but it's still within the normal range of 18.5 all the way up to 24.9. We know also by the notes that the patient appears emaciated, and we know that the reason for this emaciation is not due to anything physical. Her pancreas is working fine, liver function is normal, and looking at C-reactive protein, which is an indicator of stress and inflammation in the body, there's no indication, so everything appears normal there. So now we can conclude from the low protein, the retinol binding protein, the low transferrin, as well as from the iron deficiency anemia, that she's not really eating very well. All right, next, what could be the treatment plan? Well, the patient presents with symptoms that are typical of anorexia nervosa. Certainly, there's no reason to be this emaciated. The protein values in the blood suggests protein energy malnutrition. And there is certainly the appearance of iron deficiency, so the patient's not eating very well, and there's no sign of inflammation of disease in the liver or in the pancreas, which really is trying to rule out the causations for her abdominal pain. So now we are looking then at possibly, of course, iron deficiency anemia. So certainly a diet high in iron could be taught to the patient, maybe prescribing supplements, ferrous fumarate, over 4 to 5 weeks. The American Medical Association recommends monitoring hemoglobin and hematocrit along with taking the supplements, and if there is an improvement in the hemoglobin and hematocrit, that basically confirms iron deficiency anemia. Now, if there is no improvement in the hemoglobin and the hematocrit with the iron supplement, then the MCV could be monitored over a period of time, and of course, we would normally expect the MCV to increase, so we could check for that. In addition, we could probably check for melena or bloody stools, which would also be another reason why there could be an iron deficiency anemia. The higher fiber diet would be necessary, of course, to take care of the constipation, which is likely the cause of her lower left quadrant pain. There is in the textbook a more detailed description of what we could further investigate in this patient, and so read more about that. But this is primarily the main treatment plan I think that would be followed and that would be satisfactory. So in this particular case, we have a 43-year-old Caucasian businessman who complains of 5-year history of weight loss, of appetite or poor appetite, accompanied by nausea that has become more pronounced. He complains also of pins and needles and numbness in his legs, which is really paresthesias, and a general lethargy that has worsened over the years. He has experienced unsteadiness when standing and weakness in legs and arms. Recently, he appears to suffer from a sort of a spastic ataxia. Let's define spastic ataxia. It's a heterogeneous group of progressive neurodegenerative disorders. And we talk about ataxia, we really are referring to problems with coordination of muscles. So we have lower limb spasticity, we have generalized ataxia, oftentimes recognized with symptoms like dysarthria, which is slow and slurred speech, impaired ocular movement, also referred to as nystagmus, and then we have gait disturbance. Let's take a look at this patient's medical history. He has a history of inflammatory bowel disease, surgical resection of 75% of his ileum about 6 years ago. Prior to his surgery, he had lost about 10% of his weight, but regained it after surgery with nutritional supplements. He managed to maintain his weight up until a year ago when he experienced big drop in appetite. He began to lose weight after that. I want to take a look now at the results of the medical exam. He experiences watery stool 3 to 4 times a week. There's evidence of ataxia, loss of position and vibration senses in his lower extremities. There's a loss of reflex in his legs and a noticeable Babinski score. His present weight for height is between 10 to the 25th percentile, so poor nutritional status. His blood biochemistry, about 11 grams per deciliter in terms of hemoglobin, so slightly under the normal range. His serum B12 is 60 picomoles per liter, and that's under the 125 to 500 range. His serum folate at 28 nanomoles per liter is within the normal range. So let's look at a viable interpretation of the labs and of the exam. So first, the neurological signs are definitely visible. His serum B12 is less than the actual normal cutoff, and serum folate is normal. This increases the risk of simply being a B12 deficiency and really pernicious anemia. The MCV is normal, so no microcytosis or megaloblastosis. However, a normal MCV could occur in the case of a combined iron deficiency and a folate deficiency. There's a need to check the serum ferritin to check for the iron stores. Although serum folate is normal, serum homocysteine and methylmalonic acid could be done here to rule out folate deficiency and to confirm with the MMA B12 deficiency only. Well, what would be a differential diagnosis? Well, because there's neurological involvement, we could certainly consider the Wernicke-Korsakoff syndrome, or in other words, the alcoholic's version, if you will, of a B1 or thiamine deficiency. There's also the Guillain-Barré syndrome, which is a clear neurological degenerative disease as well, that actually resembles the neurological degeneration of pernicious anemia. So these two differential diagnoses would have to be ruled out by the physicians in order to basically confirm pernicious anemia. Well, it would be quite appropriate to discuss, what could be the possible causes of a B12 deficiency, and certainly a 75% resection of the ileum, which is the primary location of B12 absorption, could be certainly the cause. And so, consequently, because this patient would no longer be able to absorb B12, the B12 would have to be given as an intramuscular or IM injection about once a month. We'd have to teach the patient healthy eating practices to eat well according to the person's situation. And of course, depending on the serum ferritin results, which are ultimately trying to confirm whether or not there's iron deficiency mixed into all of this, an iron-rich diet then could be taught if iron deficiency is confirmed. However, the likelihood is that the drop in hemoglobin may have actually taken place as a consequence of B12 deficiency. Now, it's possible to make this interpretation because the hemoglobin didn't really drop significantly below the normal range, but is only slightly under it. So consequently, we're not looking like at a true low hemoglobin, typical, let's say, of a true iron deficiency anemia, but only a slight deviance, should we say, towards the south, and we could assume that that could be the consequence of other pathologies, notably a B12 deficiency. On page 259 of the second edition of the textbook, there's an anemia algorithm which I developed to help students basically go through the steps in discerning between the different kinds of anemias. And so here's a particular exercise to help students sort of make their way through that algorithm. Now, in this example, we have a patient presenting with fatigue, pale conjunctiva, facial pallor, and we look at the serum hemoglobin and the hematocrit, which really are consistent with most medical strategies, and we find that they're normal. First question, could the patient have an early anemia, and therefore the hemoglobin and the hematocrit, which really show up as abnormally low in the third phase of iron depletion, would in a first stage iron depletion not even be budging? So we would use the first suspicion here would be, is this an early anemia? So let's do a dietary assessment of the individual. And we do that, and if the iron intake is less than 66% of the DRI, we could certainly conclude a high risk that the dietary intake of iron is very suboptimal. In addition, confirming the fatigue. Now, we could also check serum ferritin. Ferritin is a very good value to check because it's really very sensitive to early iron depletion. So if the values are less than 25 micrograms per liter, we can then give an iron supplement and look for the normalization of ferritin, but also, well, that would be pretty much it, I guess. We would leave it at the normalization of ferritin. If the ferritin does not normalize, then we could probably conclude that there is no iron deficiency taking place. What's our second suspicion? What about megaloblastic anemia or megaloblastosis? So here we would have to check the MCV, and if the MCV is over 130 FLs, we can certainly suspect megaloblastic anemia. There would then be a need to differentiate between, is this megaloblastosis occurring because of a vitamin B12 deficiency? Is it occurring because of maybe a folate deficiency? Or is it occurring because of both being deficient? Here's a graphic representation of the algorithm as shown in your textbook. I want to take a little close-up here and move to the top of the algorithm to look at the basic questions that are followed in the example that we just saw. So I want to start at the top, right in the middle, and ask the basic question here. Are hematocrit and hemoglobin levels in the blood normal? The answer, if you recall from the previous slide, is yes. The yellow box prompts us to ponder whether or not this could actually be an early anemia given the particular symptoms of facial pallor and fatigue and pale conjunctiva. So now the algorithm prompts us to verify the serum ferritin because it is an early indicator of iron depletion, and to look to see if the iron or if the ferritin is less than 25 micrograms. If the serum ferritin is less than 25 micrograms per liter, then the recommendation then is to provide an iron supplement, teach the patient how to eat a diet high in iron, and then monitor the hemoglobin and the ferritin. And if the ferritin normalizes, then we've confirmed iron deficiency anemia, but we've also solved the problem by providing the supplement and an iron-rich diet. If, on the other hand, the serum ferritin did not drop under 25 micrograms per liter, then we need to possibly consider the likelihood of a macrocytosis. So then, if we answer yes, we have to verify if the MCV is greater than 130 FLs. If the answer is no, then we have to verify if the red blood cell is normocytic, microcytic, and verify if the serum ferritin is more elevated than 100 micrograms per liter. If it is, then we say yes and move down. And you can see when you're looking at the algorithm in your book that we can conclude that it's not an iron deficiency anemia. If, however, the answer is yes, then we have to go downward in the algorithm and verify what kind of macrocytosis is this. So therefore, if we look at the macrocytosis and we ponder whether or not it's megaloblastic or non-megaloblastic. If we say it's non-megaloblastic, then we're looking at non-nutritional causes such as alcoholism, liver disease, and others as indicated in this box. However, if the answer is yes, it is megaloblastic, then we have to consider the box right under there. So at this point, we're asking the question, is it cobalamin deficiency or is it folate deficiency? So if the serum folate is less than 3 micrograms per liter, and if the homocysteine is high, and we answer yes, then we can assume the megaloblastosis is due to a folate deficiency. If the answer, however, is no to the question, is the serum folate under 3 micrograms per liter and is the homocysteine elevated, then at this point we ask whether or not the serum folate is elevated, if the homocysteine is elevated, and if the methylmalonic acid is elevated. At this point, if the answer is yes, then we're dealing with a megaloblastosis due to B12 deficiency. Okay, now this is the end of the lecture, and I want to do some anemia practice questions with you. First question, identify the 2 markers of anemia that are used in combination with an iron supplement taken over 4 weeks to confirm iron deficiency anemia. Pause here and select your answer. The correct answer is A. Hemoglobin and hematocrit are approved by the American Medical Association as 2 good variables to follow once iron supplementation is given. If these 2 markers improve, then it confirms iron deficiency anemia. Second question, a patient presents with normal serum ferritin, low hemoglobin, low transferrin saturation, a high erythrocyte protoporphyrin, and a normal MCV. What would you conclude? Pause here and select your answer. The correct answer is B, anemia of chronic disease. What was the rationale? Well, certainly hemoglobin is low, transferrin saturation is low, and the erythrocyte protoporphyrin is elevated, and these 3 certainly indicate the possibility of an iron deficiency anemia. However, using the 4-variable model, if we look at the MCV, we see that it's normal, and we see that the ferritin is normal. So under these conditions, we can now conclude that it's anemia of chronic disease. Question 3. A patient presents with fatigue, pale conjunctiva. Doctor suspects iron deficiency anemia, but the erythrocyte protoporphyrin and hemoglobin are normal, and only the serum ferritin is low. What does he conclude? Pause here and select your answer. At this stage, you could conclude that the patient is suffering from a stage 1 iron depletion that could be confirmed by actually measuring serum ferritin. Next question. A patient presents with fatigue, pale conjunctiva. The erythrocyte folate, that's red blood cell folate, is less than 160 nanograms per milliliter. The serum folate is normal. The serum methylmalonic acid is normal, and the serum homocysteine is elevated. Hemoglobin is low, hematocrit is low, serum ferritin is low. What does the clinician conclude? Pause here and select your answer. So when we consider all these blood markers, we can only conclude that the patient has iron deficiency anemia and the patient has folate deficiency. We can't conclude whether or not it's macrocytic or microcytic because there's no MCV that was done. What's interesting to note here is that serum folate fluctuates with the recency of folate intake. We've discussed this earlier. But erythrocyte folate, or red blood cell folate, is more stable and reflective of a more long-term dietary folate status. And we can see less than 160 is indicative of a folate deficiency. A B12 deficiency can be ruled out because the methylmalonic acid is actually normal. So that leaves us really with an elevated homocysteine and elevated erythrocyte folate. That helps us conclude that it's a folate deficiency. In this next question, a patient presents with fatigue, pale conjunctiva. Erythrocyte folate is less than 160 nanograms per milliliter. Serum folate is normal. Serum methylmalonic acid is high. Serum homocysteine is also elevated. Hemoglobin is low, hematocrit is low, the MCV is elevated. The ferritin is low. What does the clinician conclude? Pause here and select your answer. Well, the correct answer appears to be the patient has iron, folate, and B12 deficiency. The iron deficiency is confirmed really here with the low hemoglobin, the low hematocrit, and also the low ferritin. The folic acid deficiency is confirmed by the erythrocyte folate, which is low, and also the homocysteine is high. Additionally, the elevated MCV suggests certainly folate deficiency, but it also can suggest B12 deficiency if we look at it in light of the serum methylmalonic acid, which is also elevated, and the homocysteine, which is also elevated, and that confirms B12. We can further physically conclude iron deficiency by the fatigue, the pale conjunctiva. Next question. A patient presents with fatigue. Erythrocyte folate is normal. Serum folate is normal. Serum methylmalonic acid is high. Serum homocysteine is elevated. Hemoglobin is low and hematocrit is low. The MCV is high. The serum ferritin is normal. What does the clinician conclude? Pause here and select your answer. The correct answer is C. Patient has pernicious anemia and anemia of chronic disease. All right, first, what is the evidence for pernicious anemia? Pernicious anemia is an anemia arising from a B12 deficiency. So serum methylmalonic acid is elevated and serum homocysteine is elevated. How do we rule against the idea that there might be a folate deficiency? Well, erythrocyte folate, which is actually very stable and indicative of the long-term status of folate, is actually quite normal, and the serum folate is normal. And what's unusual is that the MCV is elevated here, right? So we have a high MCV. This would suggest not enough B12 to convert methyl tetrahydrofolate, which is the inactive folate, into tetrahydrofolate, which is the active folate. So consequently, we end up with an inactive folate, which cannot get implicated in DNA synthesis and mitotic division of red blood cells. So note that in such instances, the serum folate and the erythrocyte folate can be normal, but note also that in B12 deficiency that sometimes you can actually see a serum folate quite elevated, because remember the serum folate is measured as a methyl tetrahydrofolate. So that amount, folate is increasing in the blood in the absence of a B12. Now, why would we conclude anemia of chronic disease? Well, first, the indications here is that hemoglobin is low, hematocrit is low, and that would certainly suggest iron deficiency anemia. However, the ferritin is normal, which suggests that that might not be the case, right? And if we look at the MCV, it's actually high, not low, as we would normally see in a microcytic anemia. So the MCV causes us some pause, but we certainly have a normal ferritin. So consequently, we can't conclude that there's an iron deficiency anemia, but rather an anemia of chronic disease, simply because the ferritin would have normally have been low in a true iron deficiency anemia. All right, finally, the last question. A patient presents with fatigue. Erythrocyte folate is low. Serum folate is low. Serum methylmalonic acid is normal, and serum homocysteine is elevated. The hemoglobin is low, the hematocrit is low, the MCV is high, the serum ferritin is low. What does the clinician conclude? Pause here and select your answer. The correct answer is D. The patient has megaloblastic anemia due to a folate deficiency and iron deficiency anemia. So why do we have a megaloblastic anemia? Well, first of all, we have it because there is clear evidence of a folate deficiency. We see it with erythrocyte folate, and the erythrocyte folate is representative of the long-standing folate status, and it's low. Serum folate, which reflects the recency of folate intake, is actually low also, and homocysteine is elevated. So all these three sort of confirm folate deficiency, and in addition, the serum methylmalonic acid, which would confirm B12, is actually normal. So clearly, the elevated MCV is related to a folate deficiency, which is megaloblastic anemia. Now, what about iron deficiency anemia? Well, hemoglobin is low, hematocrit is low, and serum ferritin is low. All three of these together confirm that it's a low iron intake or a low iron status.